Hello and welcome to the model walkthrough series. This is session 4, Caseload Model. And this is the final week of our model walkthrough series. I'm Matthew O'Reilly, member of the Demand and Capacity team, and I'm delighted to be joined today by David Aronson.
Hi, so my name is David. I'm the Cancer Commissioning Manager for South East London CCG. I'm also a graduate of the Demand and Capacity programme from NHS England and Improvement, and get involved in various sort of D&C projects around our care system. So happy to be here.
Thanks, David. So welcome to the model walkthrough series. In this series, we are showcasing 4 new demand and capacity models and how they can support operational service planning. We're not covering the principles and fundamentals of demand and capacity planning and modelling. However, you can access this information from our website, and the link to this is on the slide. If you do have any questions or queries relating to demand and capacity planning and modelling, you can email the team at england.demandandcapacityproject@nhs.net. So the model walkthrough series has been a collaboration between the demand and capacity team, the clinical workforce productivity team, and the emergency care improvement support team, and has been building on input during model development from stakeholders. Previous sessions have featured the ED model in week 1, the community and mental health demand and capacity offer and discharge hub staffing model in week 2, and the urgent response model in week 3. Today's session features another of the developmental models, a caseload model. So in today's session, we will cover an overview of the caseload model, and we will hear about planned practical application with David. So the caseload model is one of the new developmental models that we now have available on our future NHS workspace in terms of being an iterative model. The intention is for this to be published on our outward-facing website in due course. This is an Excel-based tool, as per the other models that you might be familiar with. These new models have been developed with stakeholders, and we're keen for further stakeholder feedback to continue to help shape the development of these models. The caseload model is, we believe, one of our most adaptable and flexible models, and we're very pleased to be sharing this with you at this early stage. A number of stakeholders are working to implement the model in continence services, psychological therapies, and community mental health teams in particular. Due to the newness of the model and the significant operational pressures faced in recent months, these examples are not yet as fully developed as those in the previous model walkthrough sessions. Because of the flexibility of how the caseload model can be used, we're focusing on options for how it can be used across a range of services, rather than a deep dive on how it has been used in one service. In today's session, David will talk about his plans for implementing the model across a range of different services. So, the caseload model has been developed to give another option for modelling services and pathways alongside the existing models. We know that in some instances, particularly within community and mental health services and pathways, there was not necessarily an ideal fit between the models available and the service or pathways being modelled. The core model, which you may be familiar with, essentially focuses on one-off services or stages in a pathway, such as referrals to outpatient clinics, and where the patient tends to move to the next stage of a pathway fairly quickly. It can be used for community mental health services, such as first assessments, and we've seen plenty of examples of this. High complexity model was developed for community mental health services, particularly with unstable caseloads and where patient needs change constantly. However, this has extensive data requirements for patient tracking movement, which we know has proven difficult. So the caseload model fits between the two. Initially aimed at community mental health services in development, but where caseloads or defined patient groupings can be used to predict demand. The model uses some of the principles and functionality you may be familiar with from the core model, such as SPC charts to determine a baseline period, percentiles, and waiting list calculations, but also incorporates a scenario planning tool. So, the model has been developed to help providers operationally plan capacity. Community and mental health services have been the focus in the initial development and testing. However, the model is applicable to any service where patient groupings are scoped as the basis of the modelling and may well include caseloads, clusters, localities, pathways, teams, treatments, or other defined patient groupings. The model is flexible and adaptable, so use your local scoping to determine the most appropriate option. A number of patient grouping options have been discussed with stakeholders during scoping, and these include those defined by clinical criteria, such as clusters and IAPT steps in mental health, frequency of contact, such as community-based podiatry service, types of contact with services, such as individual face-to-face contacts, group sessions, virtual appointments, treatment schedules, such as chemotherapy regimens, and David will talk more about this later in today's session. And there is also interest in using the model for allied health professional services, community dental services, and community rehabilitation services. So the model configuration comprises several elements. Demand frequency allows demand to be entered on a weekly or monthly basis. We note that for some services, demand data can be difficult to source. Feedback so far has been that this option is particularly useful. The percentile lower bound can be set from the 65th percentile upwards to take account of variation in demand. The patient group definition is selected as we have discussed previously. In this case, we have selected caseloads, and this will populate through the model as will be seen in subsequent slides. The number of caseloads or defined patient groups can be set from 1 to 15. Here we have selected 5. This will then populate through the model. We have then given each of the 5 caseloads a description. So, demand has previously been based on referrals to services or pathways, or parts of pathways, and suggested to model using the core model, covering elements such as first assessment, triage, or discharge assessments. However, we recognise that pathways, particularly in community and mental health services, are more complicated than this. In the caseload model, demand refers to the patient or service user caseloads or the defined patient groupings. And in many of these services, patients remain on the caseload for a significant period of time. Here we can see demand data entered on a monthly basis for the 5 caseloads as set up on the configuration slide. This represents the number of patients on caseload each month, and this is a snapshot position taken at the same point each month or each week if we had selected weekly data in the configuration. Usually we would suggest the more data that can be entered, the more robust the demand forecast. However, given the impact of the pandemic and lockdowns, it is important in your scoping discussions to identify and enter the demand that is most realistic for your forecasting, even if this is based on a shorter time period. We can then set a baseline period to use for forecasting. The model gives us the option of using the last 52 weeks, or selecting a start and end date. And this may be more realistic in current circumstances given the impact of the pandemic and the lockdowns on service delivery. The selected period can be seen on the SPC chart, highlighted in pale blue. This represents the last 5 months in this case. The waiting list section of the model can then be configured. This requires additions to the waiting list, the current waiting list size, start and finish parameters, which may be used to denote urgent and routine waits. An ideal or sustainable waiting list size and range are then calculated. The option for an unknown waiting list has also been included here. From discussion with stakeholders, this gives the option to include patients that may be waiting for triage or caseload allocation to be accounted for that may otherwise have been missed from calculations. The service delivery setup is where we define the planned service. How is the service intended to be delivered across the patient-defined groupings, the caseloads in this case? A further 5 treatment name options are available here. In this example, they denote a mix of group sessions, individual contacts and virtual contacts, but could be used for treatments, pathways, locations, localities, individual clinicians. There are many possible options that this could be used for, adding to the flexibility of the model. Available capacity, both a core and an ad hoc basis, if applicable, are needed to populate the model. Here, we have identified the number of minutes per week of patient-facing clinical time and the weeks worked per year for each clinician. It is important to identify and enter the capacity that is available to meet demand, that which is available in job plans. You will note the variation in the minutes per week denoting a mix of patient-facing time from 37.5 hours per week through to 22.5 hours per week on a minutes basis. The outputs of the model enable us to view comparison between required and available capacity, where the orange bar represents the upper and lower bounds of the required capacity, with the green line representing available capacity. Comparison between the ideal or the sustainable waiting list size and current waiting list is displayed, where the orange bar represents the upper and lower bounds of the ideal or sustainable waiting list size, with the cross representing the current waiting list. Here we can see the required versus available capacity for caseload 5 specifically, showing more capacity is required compared to that which is available. The waiting list view for all of the caseloads shows a mixed picture. Caseloads 2 and 4 showing that the current waiting list to be above the calculated ideal or sustainable waiting list size, and caseloads 3 and 5 show the current waiting list to be below the ideal or sustainable waiting list size. The model also incorporates a scenario planning tool that allows a number of parameters to be tested to see what impact changes to the parameters would have on the required compared to available capacity within the model. This means that you can make these comparisons without having to create separate models and compare the outputs. In this instance, purely as an example, we will look at caseload 4. Currently, this caseload has a range of 70 to 71, and we can see that the required capacity is significantly above the available capacity. Discussions once modelling has been completed may well focus on what needs to be changed to bring this back towards or into balance. Purely as an example, here we have changed the lower bound to 45 and the upper bound to 55 from the 70 and 71 respectively. And we can see that this change would suggest that there would be sufficient capacity. Obviously, there would need to be an understanding of what operationally would need to happen to facilitate such a change and whether that would even be realistic. Other parameter options currently include changing the planned appointment durations, the group sizes, and the available capacity. So, next steps, we are continuing to work with stakeholders who are interested in using the caseload model and aim to develop a number of case studies and supporting materials. Please do get in touch if you are interested. We will be sharing updates via the future NHS Workspace platform, and we would like to thank our stakeholders who've been involved with developing and testing and working on the model so far. I'm now going to hand over to David to tell us about his plans for using the caseload model.
Thanks, Matthew. So I think one of the things about this model that makes it a bit of a game changer is the type of areas you can use it now. Matthew, if you skip to the next slide, there should be a bit of a schematic overview of that. Thank you. So I'll talk about cancer services, but I think there's quite a lot of services within that are representative of where this model would be most effectively used. Typically in cancer, we've always used the core model at the front end of the pathway, where it works really, really well. Mostly the focus on the front end has been just the sheer volume of work that happens there. So 95% of cancer referrals that come through will not be diagnosed with cancer, and so they'll come off at the point of the diagnostic or investigation, and once they've received a confirmation they've not got cancer, they'll be removed. So they won't move on through our pathway. And the core model works really well there because the way those services work are very much kind of one in, one out, and there's not much recurrent kind of work. So the kind of caseload way of working is not really represented in that area of the pathway. However, in the other part of our pathways, be that treatment, rehabilitation, and follow-up, caseload working is really, really common. You see it all the time in chemotherapy, radiotherapy, our rehabilitation services, so physio and dietetics, follow up, and that can involve lots more physio, dietetics, or other complementary services. And there is a predominance of caseload working. And that's where I think this caseload model is a bit of a game changer, because we've tried to use the core model in these areas, and it is quite restrictive. It's possible, but it's quite restrictive and complex. And usually the way you have to represent the outputs requires a degree of inference, which isn't that useful when you're talking about trying to develop business cases and kind of support strategic development, where the messages need to be quite clear and very easy to interpret. And this caseload model, I think, really will provide us with that, because we don't have to do any form of other modeling to try and get those messages across. So some of the areas we're looking at within my area is chemotherapies. That's something we're working through now, because you have this way of working where patients are coming in for regimens at different frequencies, and each of those regimens will have different lengths. And we need to understand how does that all kind of add up to a top line figure of demand. And that's a very interesting question that we're trying to work through at the moment, around capturing the level of demand and how that's structured within the data set. It's quite different to what we've done previously. And there's a very key link, or very obvious link from there to radiotherapy. It's a similar issue around frequencies of visits and lengths of visits, and how you capture that within a kind of caseload model. One of the areas I'm really interested in exploring this further is our CNS workload, where you could argue it's a very similar approach. As each CNS will have a number of cancer patients on their books, if you will, but we don't really have a view of how that's balanced across our patch, and how the resources are split across services that experience different levels of demand. So it's a complete unknown, and I think the caseload model would be extremely useful for trying to quantify that and try and bring equity into that area for our patients. And another obvious area which expands beyond cancer is the kind of AHP area. So, physio, dietetics, we can also bring in the psychological support side of that. But, for cancer specifically, we talk about rehabilitation and more pre-habilitation, which is where you're kind of optimizing for treatment. These services have not really had any kind of proper demand and capacity analysis to support the level of resource available to meet the demand that's coming into the system. So we hear anecdotally all the time that these services are stretched, but we can't quantify that. And arguably that's possibly why they're so stretched, is because they've never had an appropriate kind of quantification of demand. And so resourcing is really hard to get right and really hard to plan for in the future. And in our area in South East London, we're more and more talking about pre-habilitation, and there are a couple of pilot sites up and running, and there's a lot of ambition to roll that out. But that comes with a heavy kind of caveat of what resource is required to do that, and how much of that resource already exists, if anything. How much resources in our system that we would need to uplift to meet current demand, and then what additional will be required for prehabilitation. These are all the elements where I think use of the caseload model in those areas would be incredibly valuable. And there's also other areas that I'm sure we've not touched on. I mentioned the psychological support. We're more and more talking about that within cancer services specifically, both through Cancer Alliance funded positions or CCG funded positions or Macmillan funded positions. But we've historically always relied on kind of the mental health and community services, where this model, again, it goes without saying that it would be useful there and invaluable there, in fact. And ultimately, what we're kind of working towards, our kind of bigger picture ambition, is continued use of the core model at the front end of the pathway, and an embedded use of this caseload model in the subsequent parts of the pathway that historically have not had this level of analysis on them, to build a kind of pathway level, system level view of demand and capacity across the whole, ideally the whole cancer service. But you could even break that down into specific tumour groups where there's obvious challenges, and we would aim to use the high complexity model, which has been mentioned as well, to kind of pull that all together. So I think it's really exciting to have this model in development, and I'm really keen to kind of explore use of it and understand what the challenges we'll come across will be. I am under no pretense that we will come across challenges, and there will be limitations that we come across that we'll need to think through and work through. So I am really interested to hear what other people think, what other people come across, if people are aware of any kind of obvious hurdles that we'll need to get ahead of time, or challenges in doing this type of modelling, because it's certainly new to me and new to a lot of people. And so I'd be really keen for there to be a discussion on that. If we can get some form of discussion going on the future NHS platform, I think that would be fantastic, because I think we're all kind of starting on this journey together. So to kind of learn from one another as we do that would be really, really useful. So I'll be on there. So hopefully I can speak to some of you on there as well.
Thank you, David. I'm sure we all look forward to hearing about your progress with this in due course, and options from other people as and when they start to use the model and make progress with the model. So to wrap up today's session and bring the model walkthrough series to a close, this has been the fourth in our series, and if you've missed any of the earlier model demonstrations, the recordings are available on the Future NHS workspace. To stay in touch with the demand and capacity team, you can visit our website, you can sign up to our newsletter bulletin, and you can join our Future NHS collaboration platform. You can follow us on Twitter
That's myself, Ash Mahanti and Alice Lunston, and also use the hashtag Plan for Patients. So to say thank you again to David for your insight and for joining us on this recording. And thank you to those of you for watching this recording, and we hope to hear from some of you in due course. Thank you.